All right, we're ready to begin.
Good evening, everybody. My name is Alekos Theologis. I'm one of the orthopedic spine surgeons at UCSF. I'd like to thank the Seattle Science Foundation for the opportunity to speak tonight on our interesting case discussions of lumbar spondylodiscitis surgical considerations. I'd like to also thank fellows and my colleagues for contributing their interesting cases. As a quick outline for what we'll talk about today, we'll start by talking about background, epidemiology, pathophysiology, presentation of lumbar spondylodiscitis, quick workup for it, followed by treatment strategies. I think the lumbar spine, especially when it comes to its reconstruction for these potentially complex infections, does bring into interesting surgical considerations, which we'll talk about, some pearls of how to address these surgically. And then that will be followed by three very interesting cases the first will be from Dr. Aaron Clark, who's an associate professor in the Department of Neurosurgery at UCSF. He's my wingman. He and I do a lot of co-surgeries together. So the cases that we present are those that we've done together. It's a wonderful relationship that we have built, and definitely lets us do very challenging cases. This will be then followed by presentations by two of our fellows. The first will be Dr. Rafet Kaiser. He's going to be presenting a case of Dr. Shane Birch, who's one of my colleagues in orthopedic surgery. And then Dr. Scharfman will follow that with a case of Dr. Bervens. This will be just a shameless plug for both Dr. Kaiser and Scharfman is if anyone's looking for a very hardworking, reliable, dependable, honest, and extremely talented surgeon, if you're looking for someone like that, these guys are looking for jobs. So if you have a spot available, you should definitely consider them. By way of background, spondylodiscitis, the lumbar in general, is quite common. The lumbar spine is the most common site, and this is followed by thoracic and cervical. It has a growing incidence, pretty staggering numbers, 1 in 100,000 each year. And over the last 30 years, there's been greater than 100% increase in the incidence. There's several factors for this. I think they all contribute to this increased incidence: aging population, increasing rates of IV drug use. And then in general, we're treating patients who are living longer, who are sicker, and are having treatments that keep them alive longer. And then also instrumentation and interventions in the lumbar spine are increasing. Some of which are very traditional, but some of which are somewhat more experimental. And I think this does contribute to the increase in incidence of these infections. Pathophysiology, there's a number of ways the lumbar spine can become infected. I think the most common is through a hematogenous seeding. The proposed mechanisms of this are either retrograde flow from the pelvic plexus, as shown on the right images, or bacteria that becomes lodged systemically via the end arterial network near the vertebral end plates. Local spread of infections, also a possibility. As you can see on the image on the right, an abscess in the psoas can then just infect directly the lumbar vertebral bodies and or discs. And then direct inoculation, penetrating injuries. I think this is relatively uncommon, but instrumentation, surgical invasiveness is increasing, as well as discography. Anything that is injected into the disc can result in increased risk of infection. Not done as commonly anymore, but definitely still something to consider. Risk factors for development of any spondylodiscitis, but also in the lumbar spine, are numerous. None of these are terribly groundbreaking, but anything that compromises the immune system, so malignancy, immunodeficiency through pathological states like HIV or pharmacologic immunosuppression, intravenous drug use, diabetics, quite high risk of developing infections, smokers, those who are malnourished, and then patients who have had prior or recent infection of any other organ system, urinary tract, and other intra-abdominal source or intrathoracic based pathology. Causative organisms that are important to be aware of. So pyogenic versus granulomatous. Pyogenic is much more common. the most common of which is staph, followed by strep and enterococcus for gram-positives. And then for gram-negatives, you have Pseudomonas and E. coli. Granulomatous infections, the atypical bacteria should be taken into consideration, as well as fungal infections like cocci, and then parasitic infections are less common, but should be on one's differential. These present slightly differently. They usually tend to spare the disc space because of the lack of proteolytic enzymes, so they can be confused with a tumor because they're mainly in the vertebral body. In terms of clinical presentation, lumbar spinal discitis, the most common presentation is back pain, so clearly nonspecific. The pyogenic infections and tuberculosis infections, about 25% of them present with some type of neurologic deficit. Fever is more common for pyogenic infection. I think the most staggering part of this chart is the average time to diagnosis, especially for those granulomatous infections. A delay in diagnosis, which is very common in these cases, can result in pretty significant sequelae. These sequelae consequences involve epidural abscesses, neurologic changes, pathologic fractures that can then progress to deformity of either the sagittal plane and the coronal plane, and then associated spinal instability. So that brings us to management. First thing to consider is those patients who can be treated medically. I think if you can treat them medically successfully, that's a win for everybody. I think patients who are amenable to this non-surgical approach are those who have no spinal instability, who have maintained alignment, who don't have any associated neural deficits. And then those patients who have concomitant epidural abscesses, there are some systemic findings, laboratory findings that may push one in the direction of treating them non-operatively, a lower CRP, no presence of leukocytosis, a non-MRSA infection, negative blood cultures, non-diabetic, and those who don't have signs of systemic infection. If you are going to treat them non-operatively, getting the infectious disease team on board is important. At least 6 weeks of IV antibiotics, potentially longer, and then you monitor the response to the pharmacologic treatment with inflammatory markers and examinations. Surgical indications are reserved for those patients who fail medical management with persistent symptoms, persistently elevated ESR and CRP, radiographic progression and deformity, and or the presence of new spinal instability. If a patient presents with a de novo, surgical indications for those patients would be those with neurologic compromise, especially those that are somewhat acute neurologic changes or an incomplete injury, have the presence of structural instability of the spine or concomitant deformity. And then for those patients who also have an epidural abscess, those patients who may benefit up front from surgical intervention rather than non-operative management are more elderly patients, those with increased or higher CRPs, leukocytosis, MRSA infections, diabetics, those with positive blood cultures and systemic signs of infection. Surgical treatment, the goals are to decompress the neural elements, maintain alignment, correct the deformity, and achieve fusion. The procedure options are quite numerous. I think decompression alone is something that's a reasonable thing to consider if there's no instability. That being said, there are some cases where that may not be appropriate. I think if there is associated bony destruction or any potential clinical signs of instability, then decompressing and fusing with an interbody support and debridement of the disc space would be indicated. That can be accomplished through a variety of approaches as listed there. There are some cases where both these options are not appropriate. And you can see here on the right, pretty advanced destruction of both the L3 and L4 vertebral body. And in this case, it really gets to stabilization with posterior instrumentation, decompression of the neural elements, and then leads us to anterior column debridement and reconstruction of the anterior column through some form of corpectomy. Now, when we talk about lumbar corpectomies, there are several questions to consider. The first is how many levels need to be performed. And because many times the subadjacent vertebral bodies are affected with this pathology, often 2 are necessary. This poses unique challenges in the lumbar spine because unlike the thoracic spine where you can take out multiple vertebral bodies posteriorly and reconstruct the spine posteriorly, you can sacrifice the nerve roots. That is not a possibility in the lumbar spine. So it definitely brings up the question next of which approach to take. We'll talk about that shortly. And then also have to consider what are the reconstructive options that you have in your toolbox, depending on which approach you do take. So in terms of which approaches, I think in the setting of performing one level post corpectomy, or if an anterior-based operation is not feasible, posterior operation only can be considered. You can sneak a expandable cage between the nerve roots and expand it to reconstruct the anterior column. You can do this really anywhere throughout the lumbar spine. And there are several nice papers out there that talk about, especially L5 can be a little bit more challenging because of the working space, but can be done. For these low lumbar reconstructions, one can consider doing a direct anterior operation. I think we'll have a nice presentation from Dr. Birch of one of these cases. We'll talk about the limitations of that shortly. The upper or the mid lumbar spine, I think if you want to do something that's minimally invasive, mini open, direct lateral, either through a trans-psoas approach or anterior to the psoas is feasible. And then the workhorse, more traditional approach, which is the more maximally invasive operation, is the open retroperitoneal approach to the lumbar spine. Lumbar spine is a very extensive exposure. You can access anywhere in the lumbar spine, even higher if needed. There are some things I'd like to bring up in terms of cautions about performing a lumbar corpectomy from the front, and also some associated advice. With long-standing infection of the lumbar spine, and scarring is very common, and it's pretty significant. So things to take into consideration when planning for a lumbar corpectomy of the front is, one, I would always place a ureteral stent, usually on the left side up should be your approach. The reason for this, even if you're doing a mini open operation, you don't know how the ureter is going to mobilize with the peritoneum off the retroperitoneal space. So I would do this routinely to be safe. And then when we talk about supine anterior operations, even for low lumbar fractures, L5, you can work between the bifurcation. You got to look at where the bifurcation bifurcates relative to the discs. The most challenging part of that is the L4-5 disc. You can access it through between the bifurcation, but a lot of times you do need to mobilize the vessels to the right side. When you have this amount of scarring in the presence of infection, the vessels are very stuck. They don't mobilize very well, and also finding the iliolumbar vein can be sometimes impossible. So it is a little bit risky. And then because of the retropulse fragment and need to decompress the thecal sac from the front, be prepared for it happening and then managing a ventral dural tear. So my preference, just to be, in my opinion, for me, to be as safe as possible, is maximally invasive through the open anterior abdominal approach. The incision is quite, unpleasing to many, but it gives you beautiful visualization. It can get you out of trouble or keep you out of trouble. But if you do get into trouble, it also allows you to take care of any vascular injury if one does occur. The other point of caution I'd like to make is, performing an L4 corpectomy, especially if you're associating with a multi-level like this one, doing that through a trans-psoas approach. In general, even doing a discectomy at L4-5 with a traditional direct lateral, people talk about retractor time and that putting the nerve at risk. If you're doing a discectomy plus an associated corpectomy and decompression of the posterior wall, I think your retraction time gets quite high. Now, so I caution against doing this. That being said, a good friend of mine, Coy Tan, put out this beautiful paper and beautiful result of a patient who did a 2-level direct lateral trans-psoas approach at L3 and L4 with no neurologic sequelae. So people, if they have the skill and they have the comfort in doing this, feel free, but just be cautious about doing this one through a direct lateral. The other thing to consider is staging, anterior and posterior posterior operations. Which one are you going to do first? One option is to do the anterior first, followed by the posterior. The reverse is also an option to do the posterior first and then the anterior. I star and highlight the second option as my preference because a lot of these patients are very sick. And once you do one stage, they may get stuck in a cycle of medical complexity where they may not be able to return to the operating room in a timely manner. So if you do the anterior operation, say put a 2-level corpectomy cage in, and then they get delayed and they can't go to the OR for a couple of weeks, then you run the risk of the cage displacing and the stability is still not ideal. The reverse holds true if you do the posterior first, where you can do a lot of the debridement of the anterior column through the posterior approach. You can stabilize it. You can actually correct the deformity by shortening. And then at least you have them stabilized. And if they run into some medical issue thereafter, at least you've stabilized the spine, you've decompressed them, you've debrided the infection, and then the anterior operation can be really done in an elective manner if needed. Reconstructive options. So I think more traditional options are PMMA cement. Using this, I think, is quite uncommon now, but definitely a very cheap and effective way of reconstructing the anterior column. There's structural osseous grafts that are static, so a little bit harder to fill up the space, especially if you want to correct a deformity. And then cage options, there's PEEK cages, there's titanium cages. And these cages can come in static, a more traditional option, again, a little bit harder to fill the space, especially if you want to correct a deformity. And then expandable options give you a little bit more leeway in play with filling the anterior column. They can come in circular end plates or rectangular end plates. You can even see in the image on the upper right that the circular end plates have caused an end plate fracture. So some people would advocate for placing a cage with a rectangular end plate to minimize your subsidence. So I just want to share a case example of mine, in conjunction with Dr. Clark, one of our recent cases before we go on to the panel. So this is a gentleman, 41-year-old male, got into narcotics at a young age, and then that progressed, unfortunately, to him using IV fentanyl every 4 hours. He became very emaciated, malnourished, was living on the street for years, and weighed 90 pounds, presented with back pain, leg weakness, and leg pain. He was non-ambulatory for about 6 months in a wheelchair, and really had various fixed flexion contractures of his legs because of that inability to walk. You can see here, MRI on the left, CT in the middle shows a very advanced infection of both L4 as well as L5, and then extending down into the L5-S1 disc in the sacrum and up into the L3 vertebral body. About 75% of the L4 body is obstructed, and about 50% of the L5 is large retropulsed disc fragment that was ossified. And this was a rigid deformity. So talking about our principles here, this is a patient that we wanted to stage. We did the posterior first, followed by the anterior. On the posterior operation, the plan was to do L1 to the pelvis. My traditional teaching is to go 3 above, 3 below for 3-column osteotomies in the lumbar spine or elsewhere in the spine. We did a debridement of L4 as well as L5. We took down that retropulse fragment of the L4-5 disc. We then were able to shorten him to correct that kyphosis in the lumbar spine. It was one of our major goals of this operation. That was then followed about a week later by an open anterior lateral operation, placed a ureteral stent on the left side, and then filled the open space from L3 to S1 with an expandable cage. We also did A-lifts at L1-2 and L2-3 to provide circumferential fusion to minimize the risk of him having a non-union at the upper lumbar levels. So this is an intraoperative example of that kyphus in the low lumbar spine. It looks a very rigid deformity. If we look at after our debridement, so we were able to do the L4-5 corpectomy, The L3-4 disc came out as well, took out that retropulse fragment at L4-5 and the L5-S1, the L5 vertebral bodies. So we went from S1 to L1. We then shortened over that accessory rod and then finalized that with a multi-rod construct, provided some rotational stability with the cross links. This was followed by the anterior operation. You can see a very extensile operation exposure, and then reconstructed that with an expandable titanium cage from L3 down to S1. He's done it remarkably well. Actually, he's walking. We just got a nice email that the San Francisco Chronicle wrote a paper about him, about how he's now off drugs for the last 6 months. He's functioning, he has a job. He's very miraculous recovery, and this was a team effort. So very challenging surgical intervention, but with a potential for great outcomes. And these surgeries ultimately are quite fun. So I will hand off the screen. I'm happy to take any questions as we prepare for the next part of it. And I'll hand off the screen back to Angela to bring up the interesting cases.
Yeah, Alekos, that was a terrific overview of the problem, and thank you for organizing the topic on behalf of our group here. Tell me, when you're talking about the long thoracolumbar approach, is your preference to have the patient in the supine position for the long thoracolumbar or in a lateral position?
My preference is to do it in the lateral position.
Yeah, I think sometimes for that L5 corpectomy, sort of more of a sloppy lateral or supine is my preference on that, because you're really dealing with mobilizing the common iliac vessels, but certainly lateral can be reasonable as well. I just think it's a little bit easier to get around to the right side of the patient, a little bit closer to supine. So some really great tips and pearls in there.
Thanks, Sig. Yeah, that L5-S1 disc, if you're trying to access that for getting the cage in, I think a lot of it just depends on the vascular anatomy. Some patients, bifurcation lies a little bit lower, so you can do the discectomy above it or lateral to it. But in those patients where that disc is quite, is deeper down the pelvis, you can then access it through the front. So sometimes you got to, as you do in A-lifts, access it through two portals. In that case that I showed at the end, that was all done lateral to the vessels.
Terrific.
Well, I know we have three really nice talks, and I'd like to introduce my colleague, Dr. Aaron Clark, who is an associate professor. I gave him a nice initial introduction. He's a phenomenal surgeon, and I think you guys are going to be entertained by this presentation to come.
Well, thank you, Alekos. And I'm going to get started with the case that, as you mentioned, you and I did together. It's a bit of a complex history that I'd like to walk you through. And it does show the potential long-term sequelae that a spinal infection can have in the lumbar region. So it's a 54-year-old male when this all began. He had a history of a lumbar laminectomy and fusion, very limited in the lower lumbar spine in 2008, but ultimately developed adjacent segment disease and spinal deformity. He was treated with an extension to T9, and that was unfortunately complicated by his initial infection. That was several years after the index operation. That infection led to further problems, particularly with spinal balance. And ultimately, he was extended to T4 with an L4 PSO. This was also complicated by an infection in the CSF leak that required several operations subsequently to get him through. And that all happened a few years again after that second operation. Ultimately, he presented to me when after these operations and infections had been treated, he had noted 3 months of wound drainage and some dehiscence. The cultures superficially came back as positive for E. coli and MSSA. And on imaging, you can see that on the left image, the contrast enhanced lumbar MRI, there is persistent deep abscesses, which you can see as enhancing fluid collections in his lumbar spine. On CT imaging, he has developed some lucencies at the upper thoracic areas, but in the lower area, particularly through the PSO site, it did look like he had been solidly fused. And in spite of all this, he remained globally well balanced on full-length upright standing X-rays. So as an initial step, what we did is we removed all of his hardware, did a very thorough debridement, placed antibiotic impregnated beads, and then had our plastic surgery team do a really nice closure. We kept the antibiotic beads in place and trended his ESR and CRP. This was all done in conjunction with IV antibiotic regimen determined by the infectious disease team. And with his hardware removed, he remained more or less well balanced, with which is shown on the very right in his full-length standing X-rays. Ultimately, once his CRP and ESR normalized, we reoperated on the patient, did additional debridement, removed all the antibiotic impregnated beads, and plastic surgery did a really thorough paraspinal advancement closure of the area. And we followed him for some time to make sure that he remained well corrected. He ultimately came into clinic about 3 years after the index surgery. His infectious disease doctor had said he had developed fairly rapidly progressive and severe back pain, and he complained of the inability to stand upright. So we started by getting some standing X-rays, and what we're seeing here is actually a full-length standing AP scoliosis X-ray. And clearly there's a problem. On further questioning, he did notice that due to some insurance issues, he had unfortunately missed about a month of his suppressive doxycycline, which is kind of when all this stuff started. So it actually took two standing X-rays to fully visualize his entire spine. He's very significantly sagittally malaligned, as you can tell here. But on more advanced imaging, what we noted, particularly in the supine position on the scout film as part of his CT scan, he's actually does correct in the supine position, indicating that the deformity is flexible. On CT imaging, he has had quite a bit of destruction in the lumbar spine due to a recurrent infection, and this is confirmed on the MRI image below, where there is significant amounts of enhancing tissue in that bony defect. So our plan, similar to what Dr. Theologis had mentioned earlier, was a stage 1 posterior operation. Since he does correct, we were fairly confident he would correct well when placed on the Jackson table in the prone position, and we revised him T4 to the pelvis using navigation, which really helped because you can tell from that initial CT scan he had very significant lucencies around most of his screws, or the old screw tracks, and that helped place good screws. And the plastic surgeons, again, after doing a thorough debridement, did a additional paraspinal advancement flaps and to get it nicely closed. As a stage 2 operation, we did a left-sided approach with placement of a ureteral stent to avoid problems with scarring of the ureter. Vascular surgery performed this through the large shark bite incision, and we performed an L12 lateral corpectomy with placement of a titanium expandable cage. And some of the intraoperative images show the lateral position, doing a thorough debridement with curettes, and ultimately passing osteotomes to the contralateral side to remove as much of the destroyed and infected tissue as possible, and ultimately placing a large footprint rectangular expandable cage from the lateral position to reconstruct L1 and L2. Intraoperative cultures not unexpectedly grew MSSA, which was one of his initial organisms, and he was continued on suppressive doxycycline. Here are some 2-year standing X-rays. He's maintained his correction and did notice improvement in his pain and posture. Thank you.
Thanks, Aaron. Any questions from the audience? All right. I know Aaron's got to run. He's got another commitment. So thanks a lot for joining. So the next case, yeah, go ahead, Sig. I'm happy to answer questions on his behalf. Okay. The second case will be presented by one of our current fellows, Dr. Rafid Kaiser. He has impressed all of us since starting, and he will be presenting a case by Dr. Shane Birch, one of my colleagues, a little bit different, and I think this will also highlight some of the topics and discussion that we had in the initial presentation. So, Rafid, take it away.
Thank you so much, Dr. Theologis, and thank you to the Seattle Science Foundation. I've watched many of your videos, and they're certainly outstanding educational opportunities. Thank you so much for hosting us. So I'm presenting a case here of a 73-year-old male with hypertension, hyperlipidemia, coronary artery disease, and obesity, who was accepted as a transfer at night to our hospital for concern of L5 osteomyelitis. Of note, 3 months prior to presentation, he had undergone an L2 to 5 decompression for lumbar stenosis at the outside facility. He subsequently developed postoperative wound drainage. They placed him on antibiotics, and the wound did eventually close, but we all know that this is headed where this is headed. And 3 weeks later, he developed recurrent drainage and underwent an outside workup and ultimately incision and debridement, with a subsequent incision and debridement the night prior to transfer with wound vac application. On presentation to us, the patient complains of bilateral leg pain, chills. He denies any numbness, tingling, bowel, or bladder symptoms. He was transferred to the ICU at night for desaturations to 80%. Probably related to a sleep apnea, as well as hypotension related to an inflammatory response. He did require mild pressors on admission. On examination, his motor exam was normal, except for 3 out of 5 strength in the tibiant and EHL muscle groups bilaterally. In the setting of severe pain, his sensation was intact and his rectal tone was intact. Laboratory workup showed elevated white blood cell count, anemia, as well as elevated inflammatory markers. We did have cultures from the outside facility, which showed quinolone-resistant Pseudomonas growing from deep cultures. X-rays on presentation are here. Here we see on especially on the lateral, we see erosion of the superior end plate of L5. We see osteolysis in this region. Overall, the sagittal alignment is maintained. The lumbar lordosis is 55 degrees here. We do note surgical history of the total hip replacement on the left side as well. A CT scan was obtained. This shows similar findings to the X-ray. We see erosion of the superior end plate of L5. We see anterior column collapse at the anterior aspect of the L5 vertebral body, and early stages of that middle column collapse along the posterior vertebral body of L5. The inferior end plate of L4 is also thinned with subchondral fluid collections. There is gas in the area of interest and a large collection posteriorly as well on the sagittal. We see subcutaneous gas as well as gas in the interlaminar space and a large fluid collection extending throughout. Of note, for surgical planning, we see a large vessel that has calcification in its wall crossing that L4-5 disc space. An MRI was obtained, and again, we see hyperintensity in the L4-5 disc space. We see extension of probable infection in the L5 vertebral body, as well as some extension into the L4 vertebral body. On the axial view, we see a very large heterogeneous collection in the posterior soft tissues. And on the sagittal, I suspect, this was a little before my time, but I suspect that this may be the porous signal here is the wound vac from the outside facility. So this gentleman has a diagnosis of L4 and 5 pyogenic spondylodiscitis, as well as osteomyelitis of L5. We staged this surgery. We decided to revise the debridement in the posterior column first and did a fusion 2 above, 2 below. So here are the intraoperative X-rays showing the L3 to pelvis fusion. We used S2AI screws in this case. The plan was to stage him after 24 hours and approach this anteriorly, but I think this underscores one of the important points that Dr. Theologis made earlier, that these patients are very medically complex. This gentleman's course was complicated by multiple problems. At the top of the list was a persistent GI bleed requiring multiple endoscopies, both before and after the surgery, as well as lower extremity DVT requiring IVC filter. In the meantime, during this medical optimization, we gave him a LSO and allowed him to perform activities as tolerated, and he actually, there are PT notes showing him walking the halls with them. Ultimately, he was optimized after about 3 endoscopies and vascular clippings of gastric ulcers. And we were able to perform an anterior L5 corpectomy with the anterior approach with urology placing the ureteral stents as well as vascular surgery assistance. This is the anterior corpectomy cage. We use an expandable cage in this case. I think this was a video. Oops. There was a video. So we placed this corpectomy cage, and actually it nicely restored some degrees of lordosis despite the posterior instrumentation. We did gain a few degrees of lordosis while expanding this cage. Postoperatively, his inflammatory markers did trend down. These are postoperative X-rays 1 week later. He did suffer from the medical complexities after this anterior stage as well, requiring 2 more endoscopies. And ultimately, this gentleman signed a DNR order, and he was giving up, but he made a very dramatic recovery after we treated his infection. And ultimately, he was discharged to a skilled nursing facility. 1 month inflammatory markers had normalized or almost normalized. And 6 months later, he was off antibiotics. He was actually riding a bicycle daily, and he was out of state, visiting his lake house often. He did complain of mild back pain, first thing in the morning, but otherwise he was doing remarkably well. Thank you so much.
Thanks, Rathan. Appreciate you presenting that, and really nice outcome. Any questions from the group or thoughts from Dr. Birch?
Rafa, that great presentation. I think the reason why I picked this case is because it really speaks to taking control of the patient's spine first. So that posterior stabilization with instrumentation allowed the stability. So the patient had severe compression of the L5 nerve root, which we're able to decompress, stabilize, and it got him through a lot of his medical comorbidities until he could get optimized to have the anterior approach done. So it's really nice to, lay up, if you will, and then plan for that second stage anterior approach. And this case really exemplifies sort of the approach and the algorithm that we take with these patients.
Yeah, Shane, I'll reiterate that. I really think the ability to control the spine, to shorten the spine from the back, gives a tremendous capacity. And I think you'd agree that if that cage anteriorly delayed after the anterior stage, if you did that first, those medical complications delaying the posterior stage would have made that pretty unstable. There's a question in the chat, Shane, about do you ever use any type of fixation devices to hold an anterior cage in place? And I'd say usually for me that's a bit of carpentry, but have you had any experience with that using locking screws or integrated screws for expandable cages?
No, I haven't. I mean, if you really look carefully at the X-ray, I mean, first of all, there's probably 40 degrees of lordosis between L4 and S1, and that cage has to be embedded, into either the end plate of L4 or into S1, and I think it's embedded into S1, and that really kind of locks the cage in, in my opinion, not to destroy the end plates, but there is some purposeful subsidence, if you will, of that cage to kind of get it embedded. And it's, there's a bit of an art there. You don't want to do too much, you don't want to do too little, but that's kind of the technique.
Yeah, I agree. To the point where I'd say oftentimes what I'll do is shorten the spine in the back, and if I put it in a cage on the back, shorten the spine over a non-expanded cage, and then actually intentionally expand the cage up into the end plates to get that stability there. I agree that that's a reasonable way to integrate that. I think Dr. Chapman has a question.
First of all, a big thank you to you guys for having brought up this topic. I loved hearing Alekos talk about this being fun, because I actually think these are unresolved issues, and if you deal with them in a very constructive, multifaceted fashion, they are fun because they're gratifying. They usually are extremely happy, grateful patients. And the key statement that I heard over and over again that we forget as we approach infections in the spine is that of stability. Shane just talked about that these people frequently are unstable, and we're afraid of putting hardware into these people, but actually what they really need is stability and getting them up. Now, here's my question to all of you, and that is bone healing in these patients with substantial infections. Do you use off-label BNP, which is a very strong inflammatory proposition, and makes our administrators even more happy with us for bringing these patients in or not? So your role and perception of BNP versus other forms of bone graft materials. Thank you.
Yeah, I mean, in this case, we use BNP, and typically I'll use BNP in these type of patients. I think the pro-inflammatory aspect of it helps with, the inflammation helps with sort of the eradication of the infection.
Yeah, I agree, Jens. I think certainly in the open tibial fracture study with OP1, at least, the effect size was actually reducing infections rather than difference in infusion rate. But this is one area where I'm very proactive about using BNP for exactly that reason.
I feel the same way. Shane, the L5 corpectomy can be a challenging one to do. Earlier we had talked about, what are the options from an exposure standpoint. What was your approach on this one? Was it a supine positioning? Was it anterior lateral?
Yeah, it was supine. It was sort of the standard ALIF approach. But I will say, I mean, we have great vascular surgeons, but this is sometimes it looks suspiciously easy, but every single thing is scarred in there, and it takes a lot of effort to expose that L5 vertebral body, especially with the low bifurcation.
Yeah.
And the vascular surgeons kind of give you like a grape size window when you need a grapefruit size window. And I probably spent a good hour and a half to 2 hours continuing the exposure, like getting the vessels mobilized. In fact, you have to undercut the vessels. You have to leave a rind on the dorsal side of the vessels in order to get underneath them to get the corpectomy out. It is not an easy exposure, and it takes a long time. to do this. So
Good. A useful trick that I'll add is really trying to get a big Penrose around the common iliac artery and vein. Sometimes you might choose to split the artery and vein if you just can't mobilize the vein. But as Shane said, find a plane that might involve periosteum, might involve inflammatory rind, and try and actually get all the way around those common iliac vessels with a Penrose so you can work on both sides.
Yeah. And Shane, you're the guru of the ATP. What are your experience of doing kind of a mini open approach to lumbar corpectomy in the setting of infection? Given that,
I think it works well. I mean, it wouldn't work well when you have to take it L5 and you're, trying to get around the iliolumbar vein. But anything above that, I think is fair game.
Okay.
And I have used it. It was one of the cases that we were thinking about presenting, but it does work. It does work very well.
Great. All right, thanks, guys. We'll move on to the next one. So the next one will be presented by Dr. Zach Scharfman, another one of our current fellows, and he's comes from Los Angeles. Did his training out in New York, and he's been a pleasure to have work with. Keeps us honest and make sure that we're doing the right stuff. I appreciate. Thank you, Zach. So he's going to present a really nice case from Dr. Bourbon, and look forward to hearing about it and the discussion to follow.
Thank you, Dr. Theologis, for the kind introduction. And I also want to thank the Seattle Science Foundation and Dr. Bourbon, who provided this case that I was fortunate to be involved with and learn from. So this patient is a 59-year-old male who presented with back pain and gait disturbance as his chief complaint. His past medical history is significant for alcohol use, IV drug use, and COPD. He presented with this progressive back and leg pain, and he had actually visited multiple ERs over the past 2 weeks with this same complaint and was shifted around from ER to ER. When he finally came to UCSF, the emergency medical physicians were extremely concerned and immediately got him admitted to the ICU, and also noted in the first note in our system that advanced imaging with an MRI of his entire spine would be needed to rule out a spinal epidural abscess or other issues within his spine. And I commend our emergency medicine physicians for immediately recognizing that back pain with multiple visits to the ER and fever is a good indication for advanced imaging there. He was found to be septic, encephalopathic, and hyponatremic. He was admitted to the ICU, and because he was septic, he was immediately started on broad spectrum antibiotics. Blood cultures were taken, which grew MSSA, and we know that that correlates very well with the actual specific bacteria that is in the spine, and sometimes a blood culture can help to differentiate early on if a patient needs antibiotics. Blood cultures are useful to find out what organism they're growing. His CRP was quite impressive, and his white blood cell count was also extremely high. He was grossly moving all his extremities, but his physical exam was limited by participation as he was encephalopathic. And he was deemed too unstable on post-op day one on his admission, his first day of admission, to go to the MRI scanner to work this up. He was deemed too unstable to go to the operating room as well. On the CT scan on the right, you can see that he had previously undergone decompression surgeries in the lumbar spine, but his overall global alignment is somewhat preserved, and there are the laminectomy defects as seen on the right. On post-op day 3, he had stabilized enough and he was able to undergo an MRI scan. And you can see on these characteristic images that he had multiple spinal epidural abscesses, causing significant thecal sac compression and near obliteration in his mid-lumbar spine. You can also see on the MRI that he had 2 levels with osteodiscitis and that hyperintense fluid signal within the discs. So I think something to consider in this case specifically is factors that are in favor of operation or operative intervention versus medical management. This patient's age, he was older than 50, his CRP was elevated, his white blood cell count was elevated, he had positive blood cultures, he was septic, and more than 5 levels were involved. Furthermore, he had a ring-enhancing lesion on MRI, which implies that blood flow to the actual abscess is limited and that medical management with antibiotics is going to have limited effect. Now, this patient was neurologically unexaminable, or the exam was quite limited. And because of that, that's another factor pushing us towards operative intervention, as we can't really trend his exam with medical management. So what problems did we have to address in this case? The patient was unexaminable. He had a dorsal abscess at the T8 to T12 level that needed to be addressed. He had a ventral abscess at L2-3. He had osteodiscitis at L2-3 and 3-4. And he also had a possible septic arthritic facet in the cervical spine at the C5-6 level. So those were the problems that we had to address in this patient. And because of that, we elected to take him to surgery. And I think part of the story that's very important here is understanding that this was an active and continuous discussion with the anesthesia team and the ICU team in order to optimize the patient and to get him ready to go to the operating room. That did not occur immediately, but finally on post-admission day 3, he was deemed stable enough to go to the operating room, and we took him down. So in order to address these problems, we performed interlaminar decompressions at T11, T12, and T12L1, and complete revision laminectomies at L2-3, L2, L3, and L4. We also did bilateral laminotomies for decompression at L1 and L5. We irrigated the epidural space with a red rubber catheter and with copious normal saline, and we were able to decompress the dorsal epidural abscess, which was superior to the cranial instrumented level. And that way we saved the fusion level in a structurally sound part of the spine. Lower down, where the patient had previous laminectomies, the actual epidural abscess that was dorsal was not like a liquefactive or free-flowing pus, but it had congealed and was difficult to get out. In order to get it completely out, we probably destabilized the spine more and, made the instrumentation necessary. In being able to safely access that area of the ventral canal, it required some significant removal of the facet joints that destabilized the spine and kind of necessitated instrumentation in this case. He also underwent transforaminal lumbar interbody fusions at L2-3 and 3-4, and in that way we debrided the disc space, addressed the discitis there, and were able to, from a single operation in a very sick guy, reconstruct the anterior column and ensure that in case he was not able to go back to the operating room, we've addressed his stability in that way. Finally, we fused him from L1 to L5. Fortunately, on follow-up, this patient's hyponatremia, encephalopathy, and sepsis all resolved. His cervical septic facet was treated with IV antibiotics, and his physical exam, fortunately, significantly improved to 4s and 5s of 5 throughout, and he was eventually discharged to a subacute rehab facility on post-op day 8 on an antibiotic regimen that was confirmed with our ID specialists. I think this case is interesting as it takes into account a lot of the difficult factors in these cases that necessitate a lot of pre-thought, including, are you going to stage a procedure? Can you address everything posteriorly in a sick patient who might not tolerate 2 procedures or who might not make it to a second procedure due to medical issues? And it also highlights the difficulties in the complex management and coordination of care that these patients require with our anesthesia, ICU, and infectious disease colleagues to optimize their care. I'd invite any questions or comments and ask specifically Dr. Bervin if you have anything to add or improve upon.
Yeah, Zach, that's a terrific overview. This was a case, I'm glad you chose this one. It wasn't such a complex reconstructive problem as it was a management problem. As you point out, somebody with presenting with encephalopathy, severe hyponatremia, and quite honestly, I hadn't realized the anesthetic risks of going to surgery with somebody with potentially large fluid shifts who was so hyponatremic. And so this really did require, as you said, interdisciplinary collaboration between our anesthesia group or ICU group, and having us actively involved in terms of advocating for this patient to get to the OR. So often, I think in this case, as you pointed out, even getting the MRI scan initially was really quite difficult, and sometimes we're going into the operating room without complete information. Now, one of the things I think is important to recognize in this case as well is, or maybe I'll ask this more as a question, is what are your thoughts with regard to medical management? So this person weren't septic, he simply had osteodiscitis. We saw 2 cases or 3 cases today where it involves such advanced erosion of the lumbar vertebra that corpectomies were required. And at what point can you predict that somebody is going to require a more complex reconstruction? It certainly is a lot easier to do that before we develop a pathologic fracture or bone erosion. So what do we have for predictors of when we ought to treat somebody medically, or when there is a concern for stability or concern for erosion that we'd like to actually do maybe an earlier reconstruction like this? Maybe Jens, you have your hand up. You want to take an answer on that?
We just published in the Journal of Neurosurgery Spine a validated risk score just to that end. It's takes elements of the SIN score from our neoplasia colleagues that fully gets credited, and it compares them to a number of other scoring systems. And so we take biologic factors, neurology, et cetera, in there, and it's a risk scoring. So I would love for our colleagues at UCSF to validate it or throw it out and to have their own score. But we've worked on this. We exactly saw the same need, and I think we validated in about 300 odd patients. So that's exactly the problem. We've not had that so far. Quick other things. So this case was beautifully managed. The main things here are, we did a systematic review on hardware and de novo infections. We call them de novo infections to separate them from postoperative infections. And we actually found this is not our data, so this is a systematic review, that patients who got hardware had a better survival chance and better quality of life than those patients who treated not with hardware. So again, I sensed a little bit of an excuse in Dr. Scharfman's presentation that hardware was used. If there's structural instability, if you have to take care of that infection, take care of it and stabilize the spine, just as you've shown in many beautiful cases here, and never apologize for hardware. This is a good thing if there's instability there, if there's a mechanically impaired spine. So thank you.
Yes, I look forward to seeing that scoring system. And I wonder, is an element of the score also the reliability of the patient in terms of the likelihood of them coming back?
We don't have an evidence base for that, but we've certainly included that in our own empirical decision making. But this is based on SIN score elements, which I think were very relevant, and biologic factors, nutrition factors, and we used only literature evidenced stuff. So the patient reliability we did not put in. So this can be the UCSF edition.
Just a couple of questions in the chat there. The treatment for the dorsal epidural abscess from T12, so those were skip and laminar decompressions with a red rubber that we ran along the length and actually irrigated, as Zach indicated, irrigated that epidural space with a skip laminotomies. And then with regard to an epidural drain, yes, virtually always I'll put in at least 1, typically 2 drains for these cases after these wide decompressions. And finally, in terms of the course of IV antibiotics, it's actually quite remarkable how rarely we see these patients come back with recurrence of infection. And to that end, though, typically I'm thinking about chronic antibiotic suppression for these patients. Certainly if there's polymicrobial or resistant organisms, I'm typically thinking about at least a year of antibiotic suppression and a reassessment at a year, depending on the organisms and how they're doing clinically. All right, well, I'd like to thank Alekos. Terrific topic, Alekos. Thanks for putting this together and a great spectrum of cases. And Alekos, we'll give you the last word, eh?
Yeah. Thank you to the Seattle Science Foundation, Rafid and Zach, Dr. Burvin, Dr. Clark, and Dr. Birch. Appreciate your involvement. I think it's a beautiful highlight of really fun, complex cases, and we look forward to the next time. Take care. Have a good night, everybody.
Solid work, UCSF. Good work, guys.
Bye now.
Be well.
Y'all soon.